Hi, I'm Robert West. I'm Professor Emeritus of Health Psychology at University College London, and I've been working in the field of smoking cessation since the early 1980s, and was very much involved in setting up the stop smoking services back in the turn of the century, producing guidelines. And I've been working with the services and with the National Centre for Smoking Cessation and Training, which I helped to start since its inception. So I have a very strong personal interest in what's going on in the stop smoking services in the UK. And obviously now we've got, after a few pretty lean years, we've got an opportunity to up our game in terms of our delivery of services with this extra money that's coming in. And I know that one of the really big issues always when you see a sudden influx of money is figuring out exactly how best to spend that money to get the maximum impact. And so what the Tobacco Control Alliance in London asked me to do was to see if I could come up with some kind of structure to help with the decision making for individual services or local authorities or even ICBs to help with the process, especially given how little time there is to come up with a good solid plan. So what I'm going to do is I'm going to just take you through what I've come up with as an initial offering, and I think there will be an opportunity in the next few weeks or indeed months for you to come back to us and see if we can help to flesh it out, if that would be helpful. So I think the thing that I always need to pay attention to myself when thinking about service delivery is this very simple equation, which is essentially what you're always trying to do is you're trying to maximize the number of people quitting. If it's a tobacco control policy, it may involve the stop smoking services, it may involve tax increases, mass media campaigns or whatever, but we're focusing very much on the services. So we're looking to maximize the number of people who quit through the services or as a result of the services. And how you get to that number is very simple. The number quitting is going to be the numbers attending the service over a period of time and the quit success rate, and you just multiply those two together, and that gives you your numbers quitting. The other side to this is that we're also very interested in particular priority groups, which will be different in different localities. And so you can apply that formula not just for the population as a whole, but also to any particular priority groups that you might have, whether they are, for example, pregnant smokers, low-income smokers, smokers in social housing, smokers with particular mental health issues, for example, or particular ethnic minority groups. That's entirely, of course, up to the local authority or the local group as to what you want to prioritize. But it's just worth bearing in mind that sometimes difficult decisions have to be made, because if you're going to put more resource into priority groups that are going to cost you more per quit because they need more support, which is absolutely fine and right, then you're potentially going to have less resource to put into getting the overall numbers of quitting down. And so there are decisions to be made there, to what extent you want to get your overall numbers down, and to what extent you want to focus on your priority groups. But that's, of course, entirely something for the local service. Now, within that, and trying to achieve that, obviously what all the services and local authorities are doing in developing a commissioning strategy for the EU money to get the best value out of it is to what you need to do, and what we are doing, is everyone is doing, is looking at what they currently provide, which is very, very variable. Some areas have a very good specialist service, some don't have a specialist service, some deliver it through pharmacy and so on. So there's a lot of variation in the current provision, and obviously this doesn't really make sense to think about where you're going to put your new money without undertaking a review of that. Then what you do is you're obviously going to identify the potential areas for enhancement. What are the candidates? What are the things that look potentially promising? And then what you have to do, obviously, is to prioritize, because you can't do everything. So what I'm showing on this slide is a set of criteria that have been developed over the years to help with that decision-making process. And we call them the APEASE criteria because they stand for acceptability, practicability, effectiveness, affordability, spillover effects, and equity. And all of those criteria are potentially relevant in your decision making. So, for example, if we look at acceptability, what we're interested in here is acceptability to whoever our key stakeholders might be. It might be funders, it might be the smoking population itself or the tobacco use population, it might be key community groups, literally anyone who has an interest in this. And sometimes that can get left out, and that's one of the advantages of using the APEASE criteria, is it acts as a sort of aide memoire for deciding what criteria to apply. And then a big one is practicability, especially given the time scale here. In an ideal world, you might want to, for example, if you don't have a service, set up a whole new service. But, what are the chances that you're going to be able to get that done from scratch in short order? It may not be feasible. So one has to think of, okay, well, given what we've got at the moment, where can we most quickly and easily build? And one of the things to consider there is to what extent you want to outsource it, because in some sense, I know that very often when you're pressed with something like this, and someone comes along with what seems to be an easy option, which says, "Oh, just give us the money and we'll do it for you." It can work, but you've really got to be working with very, highly trusted people, ideally ones who you've worked with before, so that you know that they will deliver. Because if they don't deliver, there's not a lot you can do about it after the event. So, these are all big issues that I'm sure you grapple with on a regular basis. Effectiveness is obviously key, because if it's not going to increase the number of ex-smokers, there's no point in doing any of it. So that's probably where I'd start in applying the APEASE criteria. I would say let's look at the things that are going to give us biggest bang for our buck, and then we can sort out afterwards to what extent it's going to be practicable and so on. So I do get asked when applying the APEASE criteria, what kind of order do you think we should do it in? And every situation is different, but by and large, I'd probably start with effectiveness, just because that's what you're trying to achieve, and all the rest of it is on the way to achieving that. And then, of course, you've got issues like affordability. The budget is great to have all this extra money, but it's not, in the scheme of things, that much. It's not actually as much as these services had right at the beginning, per smoker of the whole exercise here back in the turn of the century. So, it's still the case that decisions have to be made. And very often that means a trade-off. For example, to what extent do you go for something that's going to increase your reach of the services, and that's a key way in which you're going to increase the number of smokers, or how far are you able within the budget to increase the success rate of your services? What can you do? What are the key buys that you can put to say, well, the people going through our service get X% quit at 4 weeks and 12 weeks or 52 weeks. If we spend this much, we could boost that by 2 or 3%. And I think my guess is, to be honest, that a lot of what you're probably going to be doing is trying to increase the number of people who come through, and ideally look very carefully within the budget at how you can get the best success rates you can. But very often it's a tougher ask to increase success rates than it is to increase throughput. But that's just a general idea, so don't sort of consider that to be gospel. It's just something which I've observed. Then we have to think about spillover effects, which are things like side effects, anything unintended consequence, which could be positive or it could be negative. So you have to think, well, if we increase resourcing for this and get staff brought over from some other area, is that going to have some detrimental effect on that area of work that we're doing? So it's worth thinking about those. And then the last thing, of course, is equity. What we're always trying to do with smoking cessation, as with any public health policy, is to reduce health inequalities, not increase them. And one of the things that we know is that people in more disadvantaged groups have the same motivation to stop as people who are more well off, but their success rates are lower. So you have to bear in mind that if you do what I was suggesting a bit earlier, which is to put a lot of effort into increasing the throughput or the numbers of smokers, then you may well end up increasing inequalities inadvertently, simply because if you can increase the numbers, you can get more people trying, but people who are less well off, even with the services, are going to be less likely to succeed. So, these things are all trade-offs, and it's good if one can make informed, conscious decisions about them rather than just letting them sort of go by default. So what we're looking at in what I'm suggesting is a structured approach. And what I've done is to put together a Excel spreadsheet to help with that approach. And it's a starting point, and you can download it. I think it will be available. I can give it to you, or the London Tobacco Alliance can give it to you if you don't have it already, and then mess about with it and adapt it to your own needs. And I'm very happy to for any services or local authorities who want me to take them through it, I'm very happy to do that and give you a bit more sort of a bespoke advice given your own circumstances. So what it does is, the spreadsheet is, and I'll show it to you in a minute, is to list the possible activities, all the things that any stop smoking service does or could do. And then what you do is you say, okay, I'm going to characterize my current provision by identifying ones that we do. Then I'm going to identify what are the potential candidates for enhancement, and then we're going to discuss and put into the spreadsheet how those would meet the APEASE criteria, so that we can start to prioritize. That's the basic idea. So with that, I'm going to take you to the spreadsheet, and you can see exactly what I'm talking about. So hopefully you can see the spreadsheet there now. It's just an Excel spreadsheet, and on the left-hand side is a list of all the sort of things that a stop smoking service might do. One of those is to contribute to the regional programme, like the London Tobacco Alliance and Stop Smoking London. And these have proved incredibly good value where they've been done around the country, certainly in London, but many of you will be aware that the North East has Fresh, Greater Manchester has its programme, and to be honest with you, I think these are for many of the things that you do, these, and I'm not just saying this because I've been, this has been organised by the London Tobacco Alliance. I think you get the incredibly good economies of scale by doing a lot of things through those programmes. And if I look at what, for example, the North East has been able to achieve with what it's done, it's quite amazing. So that's, and I know that most local authorities in London do contribute to this programme, but this is certainly something that is worth thinking about. The other thing is to look at combining with other local authorities, either in ICBs or just pairing up or whatever. Again, and I know that some local authorities in London already do this. So those are just a couple of structural things that we can consider. Then we get down to the nitty-gritty of the sort of services that are provided. You've got an in-house specialist service for all smokers, in-house specialist service for priority groups, a low-intensity service for all smokers, low-intensity service. These are all potentially open to discussion about the definitions, but I think you can probably get a sense of what I mean. Specialist service is one that delivers. It's not really a matter of who delivers it. It's more a question of what they deliver, and they deliver, the full works in terms of the NCSCT manual and specification, which is based on research that we and others did in terms of what are the effective behaviour change techniques that you want to include in your service. And so that's the specialist service. The low intensity services tend to be more like kind of brief advice, a one-off session, maybe one or two follow-ups. And obviously they have lower success rates. So that's very clear, and that's what you would expect. And so that's something to bear in mind. You may want to upgrade from a low intensity to a specialist service, or if you've got a specialist service that actually isn't doing everything that NCSCT service manual suggests, you might want to think about that. But then you've got, those are all in-house, and then you've got exactly the same thing for your contracted out versions. And then I've separately listed the pharmacy service because they tend to be organized a bit differently. But even with the pharmacy service, you can think to yourself about whether it's delivering the full NCSCT package or whether it's delivering a sort of cut down version. And then, of course, we've got GP advice. To what extent are you engaged with the GPs in the area to ensure that they're giving advice? And I can tell you nationally that the proportion of smokers receiving GP advice to stop smoking has actually gone down. So it's not, I think there's a bit of room for improvement there. And it's interesting to consider how one would do that. And this is where you might, for example, set up use some of the funding to set up some more formal liaison with general practice and so on. Digital applications have become very popular, and I've been involved with Dave Crane and the Smoke Free app, which I helped to do two randomized trials of, but there are others as well. And one of the key things that I would say really strongly, if I can, about digital applications is, please don't develop another digital application, because it won't be as good as ones we've already got. I mean, I know that, there may be areas where you think, well, I like this one is okay, but it doesn't do everything I want. Far better to have a discussion with whoever the provider is and say, can you modify this, or can we build on what you've done, rather than to start again. It's such a lot of work to, and it's so expensive to create a really good digital application and evaluate it. It would be a shame just to waste the work that's been done. Then we've got the telephone service, which is interesting. In the United States and other countries, and in Australia, they rely very heavily on telephone service. Not so much in the UK, and it's not that popular, to be honest, where it is offered. And I'm not sure why, it just isn't. So that's something to think about. On the other hand, if you're paying for a service by the number of people who go through it, then, and not many people are using it, then it's not really costing you very much. SMS text messaging services are really strongly evidence-based. All of this is evidence-based, to be honest, but this is something I think, if you don't do it, is definitely worth considering, and there are options there for you to not necessarily. I wouldn't develop your own one. Again, there's ones available that you can buy into. Then we come to the medication side of things, and this is an area that I think has gone downhill a bit since I helped to set up the stop smoking services, because there's such good evidence about what the optimum medication offering is, that it's such a shame if stop smoking services don't offer that. And when it comes to, for example, NRT, it's absolutely clear that dual NRT, that's patch plus one of the faster acting products, is better than one of the products given alone. And so it really, really doesn't make sense to just provide patch or one of the products and get the smoker to buy the other product. It's just you're providing half the treatment. So if there is an opportunity to use some of the money to upgrade the medication provision there, then that would be great. We also know now that, whatever you might have heard, that nicotine vapes or e-cigarettes are more effective than nicotine replacement therapy. They just are. There's loads of strong randomized controlled trial evidence now that they are. The downside for the smoker potentially is that they continue to use them for quite a while afterwards, which costs them money at least. And they're not completely harmless. They probably have some harm associated with them. Nothing like what you get from smoking, obviously, but that's an issue. But a lot of services are now buying into the swap to stop scheme, which is a brilliant scheme, and that's definitely something that's worth thinking about. And then, of course, you've got your medication, and what's happening now, and in fact, as of a few days ago, a new drug has become available called cytosine. If you've not come across it, then do check it out. The NCSCT has a briefing note on it, and I did one of the I did the main randomized controlled trial back in 2011 that led to a spate of trials that have clearly showed that this drug cytosine has very similar effectiveness to varenicline, with fewer side effects, cheaper. The issue with cytosine is that the license, which actually dates back to the 1970s, it's just been imported from Poland, where it was been licensed since then. The license talks about 25 days of treatment, but there's good evidence that it's actually better to give 12 weeks of treatment. 25 days is okay, it's fine. It's still probably better than NRT, probably not as good as vapes. But 12 weeks will give you success rates that are similar to e-cigarettes and better than NRT, and similar to what you would have got with varenicline. So do consider cytosine as an option. Again, I'd be happy to discuss with any of you how that might look. The way to do it with 12 weeks is probably you give the 25-day course. At the end of that course, you're left on a low dose, and you just sustain the dose for another few weeks until you get to the 12 weeks, which is just 2 tablets a day. But that's all in the NCSCT guidance, so that's something that's worth thinking about. But then those are the kind of treatment issues. And then we've got things like how do you generate more smokers coming to your services? And this is where you've got things like potentially investing in outreach and primary care, outreach in community and workplaces, all really good potential investments. Better liaison with secondary care, that could be worth, depending on what you're currently doing, that could be worth investing in. Paid marketing at local authority level. Personally, I'm not sure how valuable that is. My own view, I think, is that kind of marketing is much better done at regional level. And I did a study not long after Stop Smoking London came into operation to show that London-wide activity like that can significantly increase throughput and quit rates. So that's that's something definitely to be worth looking at. You've got your own what we call owned media marketing. That's stuff that you don't have to pay for. Your emails, newsletters, all that sort of stuff. Outreach to very much worth checking. Outreach to people who've been through your services, because the research shows that if you contact them proactively, quite a lot of them will go, yeah, okay, I know I've relapsed for smoking, but I did have a good experience, and I'd like to come back. Then you've got your PR or earned media, getting buzz going in your local area with your, I'm sure you know all this, this is all stuff you're doing. And of course, your website is worth thinking about, is there some investment you could make there that might improve things? And then last but not least, we've got these sorts of structural things like staff training. There is good evidence that if you improve the access to training of staff and the supervision of staff, that you get better success rates. So that's worth thinking about. You can have a look at, is it worth putting a bit of cash into upgrading the staff resources and guidance that you give them? Doesn't have to be very much, but it could go a long way in terms of improving your impact. Your whatever insight gathering you might be getting on your local population. And then finally, of course, last but very much not least, is your service evaluation. Is it worth looking at putting a bit of money into that? So the way it works with this spreadsheet then is you take any of these things and you click on the cell here, and then if you click on this arrow, it'll give you the options. So you could say yes here. You look at this option, you could say no. Each of the options has its own cells has its own set of options. For example, here we're looking at in-house specialist service for all smokers. You could say, well, I do that directly at LA level. So you can basically fill in this to characterize your provision. Then comes the more interesting bit, which is, okay, what do I want to do about it? Do I want to set something up directly? Do I want to expand what I've got? Do I want to expand through a regional program? Do I want to set up a regional this service in the regional program? So what I've got here is all of these different options there as a drop-down list. And if you can think of other ones, then all you have to do on the spreadsheet is go to the options list, which is the second tab, and you can see that this is where the drop-down list has come from. So you can mess around with that and adapt it to your own needs. So I'm just going to go back now very briefly at the end, just to sort of sum up and see where I think we are. So what are the key principles that we're kind of working to here? Well, first of all, we want to ensure that every new activity has a clear evidence-based and evidence-informed link to increase the number of smokers created. That's what we're trying to achieve here. And so whatever the decision-making process, it should always be laser focused on that goal. Then I think what we want to try to do is to make best use of existing resources and provision rather than build stuff if there's something already there. So that, don't reinvent wheels. There's no need to reinvent wheels. There's some great services out there, not just digital services, but there's some great offerings out there, and make use of them or expand them if you can, if you've got people who you already working with who you trust. Make use of economies of scale by buying into a regional program or resources, and I think there's a lot of scope there potentially for getting really good value. Especially when it comes to things like mass media campaigns or outreach services or digital offerings, for example. I mean, really, there's a London-wide digital offering. That's what Manchester has done, and I know other areas are looking at it as well. And then really crucial to remember about the priority groups is it's really not about sort of beating them over the head to say, we've got to get you engaged, because they are engaged. They're already engaged. They really, they want to quit, and they're as keen to quit as anyone else, but they find it harder and need more support and often lack confidence or lack trust. So I think a lot of what we can do with priority groups is to make sure that our services are what they want, what they need, what they feel will work for them. And that's sometimes not cheap. That kind of thing can cost money. But, if we're looking at equity, then that's potentially an important target. And then, last but not least, engage with the evidence based on what works best in terms of engagement and success rates. Always try and go with the evidence. The evidence is not it changes, as new data comes in, but we've got so much evidence now in the field of smoking cessation over many decades of research. So, and if you have an issue, or you're not certain, you're not sure about some piece of evidence, or you're not sure whether there is evidence for X, Y, or Z, then again, through the Tobacco Control Alliance, you can contact me or other experts, and we'd be more than happy to take you through it and tell you what we do know and what we don't know.